Good morning, everyone. I wanted to start off the presentation with a question. Do you know what keeps me up at night as a pediatric GI motility doctor? Two things. One, a screaming toddler that suddenly developed night terrors. And two, that difficult patient that we all have that struggle a lot with abdominal pain and nausea, who's failed multiple medications and has a basically normal diagnostic workup. What if I told you that there's an FDA-approved diagnostic test and then give you more information about how best to help these patients and improve your patient outcomes? I'm Dr. Alice Huang. I'm the Director of Pediatric GI Motility at Cedars-Sinai. And today I'll be talking to you about my clinical experience of using gastric alimetry in my pediatric GI clinic. I'll talk to you how you can too seamlessly integrate this technology into your clinical workflow and how you can use this information to help your patients. So these are my disclosures. So first, I'm going to go into the current diagnostic testing that we have available to evaluate these patients and how they compare to gastric alimetry. Then I'm going to go into how we implemented it successfully in our clinical workflow and how it was very seamless. I'm going to also go into some challenges we encounter and some solutions to those challenges. Then we're going to go into some pediatric cases that I've encountered and how I use the alimetry findings to change their treatment strategy and improve their patient outcomes. And four, we're going to go into how you can use alimetry at your daily practice. So currently, as we all know as pediatric motility doctors, these patients with chronic nausea, belly pain, and bloating have a high clinical burden. So financially, they take a lot of financial burden, and two, it significantly affects their quality of life. And there's a lot of overlap between functional dyspepsia and gastroparesis. And when that gastric emptying scan comes back normal, they get just slapped with a diagnosis of disorder of brain-gut axis and functional dyspepsia. And then we get into kind of like a trial and error phase of what medications can best help these patients. Now, the current diagnostics that we use are upper endoscopy, which only looks at the mucosa, the gastric emptying scan, which basically tells you what is the gastric emptying rate at 1, 2, and 4 hours, depending on how your institution does it. If you're doing it the solid way with the scintigraphy, then it's mainly dependent on radiology availability. And my institution, don't tell them this, but the wait time is around 2 to 6 months to get into gastric emptying scan. So sometimes this is my rate limiting step. But the two more advanced testing for patients with these symptoms are mainly AD manometry and gastric alimetry. And between those two technologies, they give drastically different information. So for AD manometry, it mainly looks at the activity of the antrum and then the small intestine, whereas gastric alimetry looks at the gastric electrical activity through like body surface mapping. And the second information that they give is continuous symptom profiling to correlate it with the gastric electrical activity. They also differ drastically in the resources required to make these studies happen. So you can tell that on the AD manometry side, there's significantly more resources needed. You need OR time if they need anesthesia for placement. You need IR availability if IR is doing the placements at your institution. You need the pediatric GI provider to be available. There's transfers to the PACU. You need hospital beds. So you can tell that for AD manometry to happen, there's significantly more resources required. Whereas for gastric alimetry, you need four things. One, a nurse, and just 45 minutes of her or his time to just place the gastric alimetry, train the patient and the parent on how to use the iPad, and then hourly check in with them. Second, it's just a regular clinic room, no special clinic room with a call bell just to call the nurse in case something happens. Three, access to food sources because they do require a meal before the test. And the study itself is only 5 hours compared to the several-hour-long AD manometry. How they also differ is their differences of risk, right? So for AD manometry, there's significantly more risk. You have an allergic reaction to the erythromycin or the medications. You can have reaction to anesthesia. It does require radiation because they need to check the placement. You also have to have the patient that's able to tolerate a tube up their nose for several hours or replacement of the G-tube and GJ after the study. So there's a lot more risk with AD manometry. For gastric alimetry, there's a theoretical risk of an adhesive reaction, which I've never encountered in my practice, but that's a theoretical risk. Now, for the demographics of the pediatric cases that I've encountered, so I've been doing this study clinically in the last 6 months. And in these 6 months, I've done 16 cases. The gastric alimetry is FDA approved for 12 years and older, but we've done it as young as 5 years old, and they tolerate it perfectly, okay? Some of the diagnoses that I use it in is feeding tolerance, emesis, nausea, bloating, gastroparesis, and functional dyspepsia. Now, some of you might be asking, well, if my patient has autism spectrum or developmental delay, can they tolerate this test? Yes, they can. 4 out of my 16 patients actually have a diagnosis of developmental delay or autism spectrum, and all of them completed the test. The other question that I guess asked a lot is that, well, because the limetry goes on your stomach, do you need to remove the G-tube, or kind of like you can't do it because there's a G-tube present? You don't have to remove the G-tube at all during the test, like the AD manometry. You can just cut it and then put it around the G-tube. So actually 2 out of my 16 patients actually had a G-tube during the test. So was there any adverse side effects? 0% adverse side effects reported with the study. 100% of them actually tolerated the placement of the limetry patch as well as the removal. 100% of them completed the minimum requirement of 50% of the meal. 100% of them completed the entire duration of the study, no matter what the parents say, right? They get completed it. And 87.5% of them had minimal noise where it made the data interpretable. And noise is movement and manipulation of the array during the test. Now, there's another question is that, well, I know it's FDA approved, but it's still like an innovative technology, right? So what is the reimbursement like? So this includes the adult data, but when we order a limetry, and out of the 10 studies that we order, 7 are approved by insurance. And because we only schedule them if we obtain insurance approval first, 100% of them are reimbursed. Now, how will it look like at your clinical practice? So I'll go over how it's seamlessly integrated into my clinical practice. First, I order the study, and then my team gets insurance approval for the study. Once insurance approval is obtained, then we schedule the visit. A week before the visit, my nurse actually calls them up to go over 2 things. One is the meal, to tailor the meal composition to what they can tolerate. It does have to fulfill certain calories, protein, fat, and carb makeup, but they can choose what they can tolerate during the test. And 2 is to go over certain medications that have to be stopped prior to the test. Then on the day of the test, they just check into the regular clinic like they would for an outpatient clinic visit. And my nurse takes around 45 minutes to exfoliate the area, place the limetry patch, train the patient on how to do the iPad, and also how to administer the meal. It takes around her 45 minutes. She hourly checks in. She says that it doesn't really affect her time other than the initial 45 minutes. And she's running my clinic along with this study in the background. Afterwards, the test is done around 5-hour mark, and the nurse will go back in and remove it, and the patient is discharged like they would with a clinic visit. The study is then immediately uploaded to the cloud where the provider can access it. As long as you have internet, you can access it anywhere, and you can interpret it. I personally interpret it, then I run the interpretation by the Alimetry team. And then because the adult motility side also does these studies, we have monthly meetings where we go over the Alimetry studies and go over interpretations. So as you can tell, Alimetry was smoothly integrated into existing clinic workflow and required minimal adjustments to the daily operations and minimal resources to get it up and running. So there are challenges that we encounter during the implementation of this technology for pediatrics. First, children will move. They are not statues, as I know, with a toddler. So how do we kind of address the movement during the test? So we allow them every hour, 1 minute to get the jitters out and get all the movement out. So my nurse will go in there and mark off on the study, okay, this is your 1 minute to move, and they're allowed to get all of their jitters out, and then they can tolerate the rest of the hour. Another challenge we had was a lot of these kids have a gastrostomy too. I mean, this is part of the reason why to address their symptoms. And so to address it, you do not need to remove the gastrostomy tube like you have to for AD manometry. You can actually just cut the area out and then just wrap the alimetry patch around the gastrostomy tube. Another challenge is a lot of these children have very specific diets. They're G-tube dependent. They can only tolerate formula. Some of them are gluten-free. So that's why 1 week prior, the nurse actually goes over with them what they choose to eat during the meal if they cannot tolerate the standard meal. And so she will go over to make sure that it meets calorie requirements, protein, carbs, and fat composition. And the final challenge is that sometimes the children find removal of the patch cumbersome. So we've done a little bit of trial and error and found a perfect combination of adhesive remover and spray to facilitate the removal. So now I'm going to go over some pediatric alimetry cases and what I found and how it changed their treatment and their outcome. So this is our first patient, and we all have this patient, guys. This is a 16-year-old female. She has a history of dysautonomia, Sjögren's-Renaud syndrome, POTS, chronic headaches, and allergic rhinitis that I followed at the dysautonomia clinic with neurology and cardiology. I saw her for a lot of symptoms of postprandial nausea, belly pain, distension, heartburn, and constipation. Now, her prior workup has been largely unremarkable. So she's had an upper GI that was normal. She's had an upper endoscopy that was normal. And her gastric emptying scan off medication was normal. Her SITS marker test was also normal in terms of the evaluation of her constipation. And the prior medications I've tried for her is, if you thought of it, I used it. I have tried, it was a laundry list of all these medications that me and the neurologist have tried to help her symptoms. So her pre-alimentary diagnosis was functional dyspepsia and irritable bowel syndrome constipation. So her alimetry was very interesting because she didn't actually fit any of the phenotypes. So for her amplitude right after the meal went up to almost 200. So this is almost like an overreaction and a very strong electrical activity right post-meal. And then a lot of her symptoms kind of correlated with that kind of peak. And based on those alimentary findings, I was wondering, if I tackle and lower this amplitude, will she have symptomatic improvement? And so I did offer her, okay, let's do schedule low dose Zofran to try to bring down the amplitude pre-meal 3 times a day. And also when I ran this alimentary testing by the adult team, they were seeing this finding more in their patients with lupus. So the bells for autoimmune, again, kind of rung off because she does have Sjögren's and the Raynaud's. And I've always kind of suspected a little bit of autoimmune for her, but she had a negative workup prior. But because of this test, I talked to her neurologist to do more intensive testing because she also has a neurologic side effects as well. And also a second opinion with rheumatology. So 2 things happened from this alimentary finding. One, she significantly improved with the low dose Zofran to address that amplitude. She literally gained so much weight, she blamed me. But the thing is, she's able to eat without nausea, belly pain, and distension. So she significantly improved her quality of life. Second is actually, interestingly, because we did more autoimmune workup, she actually has 2 new diagnoses, autoimmune myoclonus, and she is actually positive for Lambert-Eaton. So because of this testing, we were able to look for more causes of what could be causing her neurologic and GI manifestations and gave her answers of conditions that can cause both. So in this case, I used it in 4 ways. One, it gave me more diagnostic information to work with for a patient that had a largely unremarkable workup in the past. And I used the findings of the alimentary finding to tailor the treatment plan to help her best. And as a result, she significantly improved from the intervention. 3, the findings of the alimentary were very suspicious for some sort of autoimmune component. And because of the alimentary, we did more workup and finally gave her a diagnosis. She actually reports now for IVIG, and she's improved on that. 4 is that I use the symptom profile to try to delineate where exactly are these symptoms coming from. And I saw that a lot of it was attributed to the amplitude. And so that's why I went after that, and it significantly improved her pain. So the next is another patient case. So patient number 2. And this is our 16-year-old female. She has a history of ADHD, eczema, food allergies, hypothyroidism, a previous diagnosis of autoimmune gastritis that with repeat upper endoscopy was negative. And all of these symptoms started after an H. pylori infection. So she was saying she had a lot of postprandial nausea, vomiting, regurgitation that was separate from the vomiting, abdominal pain, distension, and constipation. And she too had a largely negative workup. So repeat upper endoscopy was unremarkable. And number 2 was that her gastric emptying scan off medication was normal. So she has normal gastric emptying. Prior treatments have been proton pump inhibitor, that she was on and off use of, and IV stim, which did help her symptoms, but it was only sustained when she was currently using IV stim. This patient and family deferred all medication because they felt like we were doing a bit of trial and error of what can best help her, and they wanted more diagnostic testing to help them guide the treatment options better. Her pre-alimentary diagnosis was rumination, functional dyspepsia, and irritable bowel. So for her, there's actually 2 findings, but I'm going to focus on one of them. She had a very high frequency with the meal responsive symptoms. So we diagnosed her with hyperactive stomach. And because of the high frequency is seen after more infection, hers was after H. pylori infection. And 2, it is more associated with kind of vagal nerve injury that will explain why she responded so well to IV stim. And so for the IV stim, we were able to restart it, and she did have symptomatic improvement. But once again, it was only sustained when she was on IV stim. So I needed a more permanent option for her to improve her symptoms. But because of the alimetry test, the patient and family were now more open to trying medications because they had a test to kind of hinge on of what she would most benefit from. So they were willing to try things like Emend. So the Emend actually resolved all of her vomiting and regurgitation, improved her nausea and belly pain significantly. She also gained weight and blamed me and said that her skin was glowing. I'm not a dermatologist, but wonderful side effect. And so the vomiting resolved, and she actually returned back to school, which is a really big win for this patient. And so for this patient, I use alimetry a little bit differently. I use it to give the patient and parent a little more diagnostic information that can help guide treatment so they didn't feel like we were doing a bit of trial and error with them in trying different medications and seeing if it worked or not. And number two, from the finding of the high frequency, I was able to tailor her treatment to help her symptomatically improve. Now, patient 3 is our 10-year-old female. She has a history of ADHD and failure to thrive. She had a lot of postprandial abdominal pain, distension, nausea, constipation. She was also had a lot of malnutrition, and all of this has been happening with fluctuating nature since she was 2 years old. So she differs from the other patients because she actually does have an abnormal gastric emptying scan. So her upper endoscopy was normal, but her gastric emptying scan was positive for gastroparesis with 20% retained at 4 hours. When she saw me, her previous GI doctor had started her on periactin, Buspar, erythromycin, and a diagnosis was gastroparesis, chronic constipation, and malnutrition. So for her gastric alimetry, we saw actually two things. We saw the high frequency that we saw with the last patient, but for her, I'm going to focus on the hypomotility. So her peak of her electrical activity didn't happen until 3 hours and 30 minutes to 4 hours. So there's a delay there. And using those alimetry findings, I was able to prioritize the pro-motility agents over anything that increased gastric accommodation or appetite. And so for her, I started palicarotide and also optimized her erythromycin. And the direct quote from the patient and the parents, she felt the best she ever had. So that significantly improved her postprandial nausea and belly pain, led to more weight gain, and whenever you have a patient that's been having symptoms since she was 2 years old with fluctuating course, low weight percentile, you kind of worry a little bit, is there something sort of genetic or systemic that's happening, especially when it involves the upper tract and the lower tract. But because she had those findings of the gastric hypomotility, I didn't feel the need to rush an AD manometry and clonic manometry on her. So two things that I use the alimetry in this case scenario. One, it provided me with more diagnostic information of should I focus more on cyproheptadine and improving her appetite and gastric accommodation that way, or should I focus on pro-motility agents? Her alimetry clearly showed I should probably go after the pro-motility agents, and she significantly improved from that. And two, it also helped me kind of stratify what is the urgency in getting an AD manometry and colonic manometry on this patient. In other case scenario, I will be worried because this has been happening since she was 2 years old and she's lower weight percentile. But because I saw that on the alimetry, I wasn't too rushed about it. She's still getting the AD manometry and colonic manometry, but the chances of it will be normal based on the alimetry is higher. Sorry, guys, this is patient 4. So this is our 20-year-old female, and we've all had this patient on our repertoire. She has a mood disorder with possible bipolar disease, a diagnosis of gastroparesis and chronic constipation. She's had multiple admissions in the past year for eating disorder. So she's been in and out of eating disorder inpatient units because of low weight. And she also has a diagnosis of MALS that was responsive to celiac nerve block. She was coming to me for a lot of postprandial nausea, vomiting, belly pain, distension, constipation, and weight loss. So for her, she actually had a lot of abnormal prior testing. One of them, the upper GI with a small bowel follow through. Anatomically, it's normal. And I know I shouldn't use the transit time, but her transit time of the contrast to the small bowel was very delayed. The second one was her upper endoscopy was normal. Her gastric emptying scan was abnormal off medication. And because of the persistence of symptoms on pro-motility agents, I repeated the gastric emptying scan on medication, and it normalized. It was a normalized rate. And so her SITS marker tests were also abnormal with slow transit constipation. Prior medications have been trying to optimize her appetite and her accommodation with periactin. I have started her on palicarotide, mestinon. I've tried all the pro-motility agents and PPI, but they all stopped working. So her pre-alimetry diagnosis was gastroparesis. She also came back positive for hydrogen SIBO, slow transit constipation, and malnutrition. So you'll see for this patient, it's really difficult to differentiate where are these symptoms coming from because everything looks slow. So for her gastric alimetry, she looked similarly to the last 10-year-old patient. And so her gastric activity didn't peak until the 2.5 to 3 hour mark. So she actually fell into the category of gastric hypomotility. The other interesting about her was that we were asking the question of where are these symptoms arising from? Because she has multiple issues going on, right? Is this more from the gastric activity, the gastroparesis? Is this more from the SIBO and the slow transit constipation? Or is this more centrally mediated, so more visceral hypersensitivity? And so you'll see here on the symptom a burden is that everything kind of improves right at that 2 hour and 30-minute mark when her gastric electrical activity kicks in. So I did see a correlation that she will have symptoms, and then once that stomach activates, the symptoms improve overall. So using that data, I went after the stomach because that's where I think that her problem was. Unfortunately, because of severe malnutrition, I had to do an NJ tube to bypass that area for nutritional optimization, and I optimized what I can of her pro-motility agents. After she came back all the way from the NJ and she was able to tolerate her normal diet off the NJ was self-removed, and the symptoms all significantly improved. And after a year of in and out of eating disorder units, she's actually back in college now, studying anything but medicine, but she's back in college now. So 4 ways that the Alimetry helped me in this case. So 1, it provided me with more diagnostic information to try to delineate which medications will help her best in the next steps. Because for her, her gastric emptying scan normalized on pro-motility agents. So if I didn't have the Alimetry, I won't have gone after the pro-motility agents. I would have gone more for the gastric accommodation. But the thing is, the pro-motility agents is what helped her most. 2, it stratified the urgency, again, like the last case of the 10-year-old, of how quickly do I need to run to AD manometry and colonic manometry? With someone that had confirmed slow transit and gastroparesis, you will wonder, okay, is there something systemic going on? But for her, because she fell into the category of hypomotility, I was a little bit less rushing to AD and colonic manometry. 3, especially with someone with such a complex history, we wanted to differentiate where exactly are these symptoms coming from? Is it coming from the stomach? Is it coming from what's called post-gastric profile, so the small bowel and the constipation that she had? Or is it centrally mediated? And this test was allowing me to designate that most of her symptoms improve once that stomach activates. So that's what I went after, and that's what she improved significantly on. And 4, if she did have persistence of these symptoms, I could have repeated the Alimetry on medication to see if those changes persist and check the efficacy of these medications. So patient finds our final patient. And this is our 16-year-old male. He has cerebral palsy, anxiety, and he has a deep brain stimulator for dystonia. He had a long-standing history of feeding intolerance, of which it required a G tube. I was mainly seeing him for postprandial emesis, regurgitation, what appeared to be abdominal pain and irritability after G tube feeds, and inability to advance G tube feeds as continuous feeds. He also had a lot of abdominal distension and constipation. So for this patient, an upper GI with a slow infusion of the contrast showed that anatomically everything looked normal. His upper endoscopy years ago showed EOE, and it hasn't been repeated yet. His gastric emptying scan has never been able to be performed because whenever we would try the gastric emptying scan, he would vomit. So it was never be able to be completed. His prior treatments that his prior GI doctor had him on was ciprofloxacin and domperidone that they were sourcing from Canada. Parents were questioning if it was working or not, but because he's been on it for so long, that's why they continued to have him on it. But they were running out of supply because of the tariff situation. He was also having proton pump inhibitor and enemas. So his pre-Alimetry diagnosis was feeding intolerance that we see a lot in patients with cerebral palsy and chronic constipation. Now, his Alimetry shocked me because I thought this was just a cerebral palsy patient who had a lot of feeding intolerance, which we know that they have. But his Alimetry showed gastric dysrhythmia. So it was completely unorganized and not much of a meal response. So he actually has a gastric neuromuscular disorder. And based on those Alimetry findings, it was questionable if he, number 1, was responding to the domperidone at all. And number 2, is that if I replaced it, would it worsen his symptoms? Because he was running out of domperidone, we had to replace it if it was working. Using that test, though, I was able to counsel the parents and patient, the patient is developmental delay, but I was able to counsel the parent that, hey, he fits a phenotype where they don't really benefit from pro-motility agents. In fact, they might get worse, but just letting you know in advance if we start pulcalopride just to keep an eye out. And true to the alimetry findings, he actually worsened on pocalopride, and they didn't see any changes when stopping domperidone. So I doubt domperidone was working at all either for him. So in this case scenario, alimetry was able to almost predict how he will respond on pocalopride. He continues to be G-tube dependent, and because I saw dysrhythmia on the alimetry, I was like, this kid needs an AD manometry, and so I referred him for AD manometry. Unfortunately, the parents said that they don't want to submit him through the risk of AD manometry. They were okay with the risk for the gastric alimetry, and so they wanted to hold off on the AD manometry. So you'll see here in this case, alimetry was used a little bit slightly different. So it was able to actually give me prognostic information, whether a patient would benefit from a promotility agent. Number two, this one definitely upped the urgency of the AD manometry. And like in any other case scenario, I would have thought, okay, feeding intolerance, cerebral palsy, right? But in this one, because I saw dysrhythmia, that's why I put in that referral for AD manometry sooner than I would have without this testing. And three, it permitted the parents to have access to another study with lower risk, right, than an AD manometry, but also give them enough information to go off of and change treatment strategies. So it was nice for the parent to have options to both types of testing. So you see here that the core insights I want you to take away from this presentation is one, gastric alimetry is a FDA-approved diagnostic technology that should be essential to your clinical workflow because one, it can help you kind of tailor treatments to the findings, and two, help you improve their patient outcome. Two, gastric alimetry can be seamlessly integrated into your clinic workflow without any sort of interruptions to your current operations and it requiring minimal resources. And three, gastric alimetry can be used in a variety of ways. I personally use it to guide my treatment options and therefore improve their outcomes, as you can tell from all my pediatric cases that I presented. Two, it also helps me differentiate where are the symptoms coming from and where to target to best help their symptoms. So is this more gastric? Is this more post-gastric, so focused on the small bowel and constipation? Or is this more focused on central mediated, so visceral hypersensitivity? Three, help me stratify who do I refer for AD manometry and colonic manometry. And four, if I repeat it on treatment, it'll help me assess the efficacy of the treatments that they are currently on. So thank you so much. This is my email if you want to keep in contact with me.